Today I'm going to talk about the Palliative Performance Scale by Jennifer Smith. The Palliative Performance Scale is a very useful diagnostic tool that is commonly used in hospice and palliative care. This tool helps to determine patient hospice eligibility and to predict length of stays. To be admitted to hospice, someone must have a life expectancy of less than 6 months. The hospice Medicare benefit requires the patient's attending physician and the hospice medical director to certify that the patient admitted has a prognosis of 6 months or less if the disease runs its normal course. Hospice programs have a definite need for an objective measure of prognosis in terms of length of survival. Physician establishment of prognosis is a key factor in timely hospice referral and facilitation of maximal benefit from hospice care. The hospice program is held accountable for continued evaluation of the patient's prognosis and discharge of the patient if the prognosis deviates from the 6-month prognosis. So why is the PPS useful? Prognostication is particularly important in terminally ill patients and is crucial for making decisions regarding goals of treatment, and it also enables providers to decide on realistic treatment plans for the patient's remaining time frame. This helps to empower patients and caregivers to plan for care which respects the individual goals. Understanding a patient's prognosis also helps providers to be more judicious in the use of treatments and in the allocation of resources. The Palliative Performance Scale is a modification of the Karnofsky Performance Scale and encompasses 5 observer-related domains. The PPS not only examines the degree of functional independence and disease burden, but it also has domains of self-care, oral intake, and level of consciousness, the temporal change of which may reflect physiologic response to disease progression. It is divided into categories from 0% to 100%, and it fully represents a spectrum of independence from full functionality at 100% to fully dependence with minimal oral intake at 10% and death at 0%. The PPS has proven correlation with survival at grouped percentile categories, as well as each 10th percentile category. As the PPS score only takes into account a patient's functional status at a particular point in time, documenting the change in PPS scores between 2 time points helps the physician to appreciate the rate of the patient's functional decline. For instance, taking one on admission and then in about 2 months, you would do another one routinely. For most terminal diagnoses, it is likely that the higher rate of functional decline corresponds with the more rapid deterioration and shorter survival. Hence, the change in PPS scores could aid in survival prediction. Advantages of the tool are simplicity due to written instructions and definitions accompanying the tool, circumvent the need for any additional training, and speed the use of using the tool. The strength of the PPS as a prognostic guide is that it evaluates the patient's performance status, including ambulation, activity, extent of the disease, and self-care, similar to the KPS. But it also adds an evaluation of intake and level of consciousness. I have 2 graphs here that I was going to show you. The first one here is survival time based on the PPS score on admission. So you can see here that the lower the score of PPS on admission, the shorter the predicted survival time. So this here, the top one, 10%, is this first line right here. You can see how drastic it kind of drops off and how short survival time there. And then this one here would be 20%, 30, 40, and 50 on, and this last one out here would be 70. So the higher your PPS score on admission, the longer predicted survival time that you have. And this other slideshow here shows a change in PPS from admission. So if when you do it on admission, then you do it again in 2 months. If they have a change that's greater than 30%, it's highly predictive for having a bad outcome or for increased decline. So this top line up here is less than 10% change, and then 11 to 30% is the middle line, and this bottom line here is greater than 30% change in their PPS score from admission. So you can see that the greater change in their PPS score is more predictive of a decreased survival time. Next, we're going to go on to showing the actual scale here. So this is the PPS score here. I'm going to scroll up to the top here. It was made by the Victoria Hospice Society, and it's meant to start at the left column where it shows the PPS levels, and then go to the right, and each one of the columns is what you're measuring. So you first want to evaluate them on their ambulation status. Are they full ambulation, reduced, mainly sit-lie, mainly in bed, totally bedbound? Hopefully you can see these numbers on the side. They got kind of cut off, I think. So if your patient is, say, mainly in bed, you'd start here at the 40% percentile line, unable to do most activity, extensive disease, mainly assistance. We'll say they met this, but then they required total care. They really couldn't do anything, provide any of their own care. So you would drop down to the 30% line here. And then if their diet, if there's normal to reduced, you would stay at the 30. But if they were taking minimal to SIPs, then you would move down to the 20%. And then here, if they're full or drowsy with some confusion, you would stay at this line here. But if they are drowsy or minimally responsive and confusion, then you move down to the 10% bracket there. And then down here it just talks about instructions about use. Where I work here, with hospice, we have all our PPSs are on the computer, and you just click the appropriate boxes, and it kind of grays out the boxes that aren't applicable anymore. So it guides you in which way to go. This has some examples of different types of patients that you could score on here. The first one showing at 50% here, who spends the majority of the day sitting, advanced disease, needs considerable assistance to walk, but is fully conscious with good intake. So that puts them at the 50 percentile. So if you look up here, it's mainly sit-lie, unable to do extensive disease, needs considerable assistance, normal or reduced intake, and normal conscious level there. And then example 2 talks about, if they're paralyzed and quadriplegic requiring total care, they would have a 30% PPS because they're totally bedbound, total care. They could be eating and have a normal intake if they are being fed. And example 3 refers to a paraplegic who may be bedbound but could still do some self-care and could feed themselves. So although they're completely bedbound, which would normally be 30%, and you don't normally go up on the scale, you usually just start one and go down. But so 30% unable to do any activity, total care, but actually they'd be mainly assistance here and normal reduced diet, so they could go up a little bit in that circumstance and be more of a 40%. If you scroll down further, this just talks about definitions for the different topics, as ambulation, how do you define mainly sit-lie, mainly in bed, totally bedbound. Usually that's pretty clear, but one thing I know that gets confusing sometimes is with totally bedbound patients. Sometimes caregivers get patients out of bed and put them in the chair, but if they can't get out of bed on their own, they're still considered totally bedbound, even though they may spend the majority of the day in the chair, but they can't get themselves out of bed into the chair, and that's still considered totally bedbound. The extent of their disease here talks about, it's considered significant disease if they have a few metastases, 1 or 2, extensive disease if they have multiple metastases, like to the lung, bone, liver, brain, that kind of thing. Talks about self-care, what's considered occasional assistance, considerable assistance, mainly assistance, and total care. And it also talks about intake and conscious level here. And that's pretty much it. Hope you enjoyed my presentation and will find it useful. Thank you.